Thank you very much for the opportunity to discuss our paper that was presented at the American Society of Hematology meetings in December of 2016, entitled VTE-Related Healthcare Resource Utilization and Costs Associated with VTE in Cancer Patients Treated with Anticoagulants. VTE is a common complication in patients with cancer. The standard of care for treatment of venous thromboembolism is low molecular weight heparin or another anticoagulant for at least 3 to 6 months. Besides low molecular weight heparin, oral anticoagulants, warfarin, and rivaroxaban are widely prescribed in the United States for treatment of VTE. It's been estimated that all-cause healthcare costs for cancer patients with VTE were $30,000 higher than those without VTE. In a previous claims-based data analysis, rehospitalizations related to VTE were lower in patients treated with rivaroxaban compared to patients treated with low molecular weight heparin or warfarin. The objective of this study was to compare VTE-related healthcare costs between cancer patients treated with different anticoagulant therapies. As you can see in this schematic of the study, this is a retrospective cohort study of Humana claims database of over 10 million members from January of 2013 through May of 2015. We captured patients that were eligible at the time of the initiation of the study who also had a diagnosis of cancer and had a thrombotic event during their course of cancer therapy. We then identified patients by dispensing data when they were started on anticoagulation and then followed them forward for clinical events and costs related to those clinical events. We excluded patients that had a prior VTE or were using anticoagulants before the study. Our study cohorts were those that are being treated with low molecular weight heparin, warfarin, or rivaroxaban. We did not include other agents because they were utilized in a small proportion of patients. We used an inverse probability of treatment weights based on propensity score to adjust for differences between the treatment cohorts for the following comparisons: the low molecular weight heparin cohort versus rivaroxaban, and rivaroxaban versus warfarin. These were the outcomes we looked at. VTE-related resource utilization during the treatment period was assessed in the number of outpatient visits, the number of ER visits, the number of inpatient visits, and inpatient days. We also looked at VTE-related healthcare costs during the observation period, including total costs, pharmacy costs, outpatient costs, emergency room visit costs, and inpatient costs. As you can see from this table, the groups of patients were well balanced according to what type of VTE they had, age and gender, and their comorbidities, as well as healthcare costs prior to the diagnosis of their venous thromboembolism. In these results in Table 2, you can see that costs for hospitalization were higher in patients treated with low molecular weight heparin than those treated with rivaroxaban. Pharmacy costs were also higher, as were outpatient visit costs. In the comparison between rivaroxaban and warfarin, you can see again the total costs were similar. Warfarin had lower costs for pharmacy costs, but higher costs for outpatient visit costs related to the need for chronic monitoring of warfarin in outpatients. Our conclusions were that healthcare resource utilization and costs associated with VTE-related treatment in cancer patients were highest for patients treated with low molecular weight heparin relative to rivaroxaban. Healthcare cost utilization were significantly higher for warfarin relative to rivaroxaban, but resource costs were offset by higher drug costs of rivaroxaban. These results are in line with previous studies in cancer patients that found fewer rehospitalizations related to VTE in patients treated with rivaroxaban compared to patients treated with either low molecular weight heparin or warfarin. Thank you.